Okay, guys, good evening, everybody. Uh, I think all of you know me, but even so, I'll introduce myself. I'm Dr. Ahmed Abu Aisha or Ahmed Suleiman. I am a dentist since 1996. I graduate. Okay, I will talk with you about my personal experience in implantology, which start in 1998. First course I take in dental implantology in that time, 1998. Now, when we talk about past, sure, it is more than 20 years. And what the implantology that time was for us and what it is now. It helped us in what and what is now. There is different, but this different. Now, let's go as a trip to the past, okay? And here we will go together to the past, count till 10, and you will be in the past and see my clinic before 20 years. I put like this. 2, 4, 5, 6, 7, 8, 9, 10. This is not me, okay? But she was my assistant in 2003. This is me. Wow. How I look? Really, it's different. That course is laser course, not implant, but this is the picture what they found. I used to have courses. Sometimes I give courses in my clinic because it was a really big clinic that time in Jordan. This picture, sinus lifting in egg course. So we was studying. We was doing something. We try to do. We used to study too much and read and present. But the problem, yes, surely there is some changes in dental implantology. And when we are talking about changing, not only in the designs of implant or in the kit or whatever, and not only in the equipment, what you are using. There is changing in the equipment, but not only that, and not only the performance, what you are doing. When you are doing the drilling, Dr. Mar'i, he said, we used to look to the bone, where is he? He ran. Like a wood, like we are carpenter. We was like this before because we look where there is a bone, put your implant, that's it. Whenever your implant is go, it's good. The real way the changes, it was in the way, our way of thinking. Now, when I'm talking about 2003 and 2023. This time. And what's happened exactly, it's not because of the time. There is some time it's come, or some period it's come, some like you say, you are in the way. Because whatever I learned in 2003, I kept doing it until 2018. I don't change anything in real way. So what is changed, not as I said before, the equipment or the designs or the performance, what is changed, something else in my mind. My mind is changed. So how is changed and who changed it? All my information about implantology, all my experience, 20 years, all together, it has some put in my mind, what I call it before IDSC, which is totally changed and totally start to be something else, and they start to have a new mind, which I call it now mind of implantology, but after IDSC. Here is the point. Here is the difference what's happened with me. And I think with all of you, as Dr. Mar'i say or Dr. Razan say, yes, IDSC is changing us something. Now, first, psychological change. This was big for us. Because really I doubt. All my 18 years I was doing, till 2018, I was doing dental implantology to get more money, to get more patient, not to change something. Because I don't know, just, okay, the patient need a bridge, okay, I'll do for you bridge. What you need? You need implant, I'll do for you implant. I wanted to be one of my product in the shelf. This is what I was looking for. Okay, now, in the same time, I was having doubt. Actually, till today, some doctors, they have this doubt. Did the dental implantology is a good specialty for me? because I don't look to it as a specialty or something I do. No, it's something that I can sell. صح? All of it. So now in that time, before 2018, it was, as I say, it was a product in my shelf. So whatever the patient he want, I do. Now the problem, before 20 years, we was fighting to change from bridge to implantology, but same concept. I want some product in my shelf that I can give my patient. It is more expensive than the bridge, so I have to put it. But same time, there is some belief inside me that dental implantology is better than bridge. Sure, there is something here I'm doing. I'm breaking 2 teeth to put one teeth. So sure, dental implantology it's better, but in same time we was fighting to change from bridge, from this to dental implantology, not only with patients, because it was difficult before 20 years, believe me, to convince the dentist to perform dental implantology or dental implant. Because till before 2 months, I see in social media movie for one dentist, she's saying dental implant cause cancer. 2 months before, not long time, yani. Till today there is fight about this. But sure, it is different now. That time, can you imagine in 1998, you are doing implant, so how it is? Any dentist who doesn't know implant or he doesn't take course in implant, directly he will tell the patient, no, don't go for implant, go for a bridge. Why? Why, doctor, not implant? Because this one. So we was fighting in real way that time. But still, because there is something inside us or inside me, believing in dental implant, no, I decide to go on with dental implant. So convincing myself this is good business for me. Now, after IDSC, see, this is the mind changing what I'm talking about. After IDSC, I start to have appreciation. I'm very glad and thankful to be an implantologist. Really, I'm very glad. Now I'll tell you why I'm very glad. And I think you will be glad with me to be implantology because I give. Why? Okay. Yes, we have all to be glad because really we can give our patient very good quality of life. We cannot give life, but we can make them life better. Now, in this case, her name Razan. She's 34 years old. Now I make change. You see how much change happened? But really big change. Now where is the bridge and the crown will do anything here? You know, she lost her teeth because of crown. I'm not against the crown when you do it right. But you know there is a shelf life for the crowns. There is a shelf life for a bridge. There is a, you know, by literature, you have 10 years maximum or 15 years, and this depends in the patient. Did he clean? Did he not? Did he maintain? Did he not? But more than that, this is what will happen. In 34 years old woman, this is her teeth. I change it. I give her life. I give her a smile. And what makes me really happy to be implantology, this is 6 implant for her. We put it, as you see, it's nice. This parallel and like this, we learn here in IDSC. Before, if it is like this, it's okay for us, no problem. But one time, Dr. Suhail shout and fight with me for 2 implants. Dr. Aisha, she remember that? Now, but it is parallel, right? It's good. Now, this is the message what is give me appreciation to be implantology. When you have this such kind of message every, let's say, 1 year, one patient, 1 year, this message, you will not be happy to be implantology. Okay, who can read? Now, every time Dr. Sohail will keep asking somebody to read. Can I do this, Dr. Sohail? Only today. So read, please. No English.
Good evening, Dr. Ahmed. I wanted to thank you from my heart. The key number of things that
I can do.
You tried off for years, eating, talking, self-confidence, when I talk to people, everything is different. May God bless your efforts and benefit people with your knowledge. In fact, you not only solved my medical problem, but you changed my life. May God be blessed with you and open up to you and increase knowledge, I will pray for you with every prayer.
This kind of message, if you have one like this message every year, you will be very glad and appreciate that you know how to put an implant. But as we say before, to know something and to think something else. Now, this result, this patient, it's come after IDC because before IDC we do a lot of things. God knows what is it. Okay, now let's go what we exactly, how we learn in IDSC. Now, first thing we learn, why should I choose a certain design for implant, for prosthetic, for abutment, and reject another? We don't know that time. We know only who can give me more implant with less price. This is what I care. Who's the company who will send what they call it, المندوب? Huh? Sales rep every day, keep coming, nagging over me, take my implant, take my implant. That guy, I will take him. I'll take his implant because they don't look to the design of the implant. Now I know why I should choose something. Now this implant, before 20 years, I bought it. You will see the panoramic X-ray, but don't talk too much about it, okay? Now it will come. First thing, you see that, right? The thread, where is, you see the bone resorption here? You see it? Very obvious, right? Really. Dr. Suhail, he keep insisting, keep nagging over our head. The stress, the bone will go to the first thread. So now this kind of implant, we are not using. Even if the sales rep or medical rep, he stay in my clinic, even he start to give me the implant free of charge, I will not take it, right? Because this is the result. I know now. Before we don't know, really. I don't know what implant should I choose. Now I know. Okay. Now, which design helps stabilize the bone? Height and width design cause the bone resorption. Box. Dr. Suhail, he called it box design. Okay? This is not my implant, this is from internet. But I found this one. And you see, the bone stay with the first thread. Now, these designs, we know that we cannot buy. We should not use anymore. خلاص, cross. We cannot use them, even if they are free of charge. Now, what should I be sure of? This is very important point. Also, Dr. Suhail keep telling us 2 millimeter of buccal bone. Believe me, we don't know that this concept. We don't. Before 20 years, we didn't know what bone you have to leave. Halas, there is bone. Put your implant. Finish. We don't even think about 2 millimeter of anything, or 3 or 4, whatever. Now we know that if I don't have 2 millimeter buccal bone, I have to add it. I have to put it the same surgery. I cannot leave it. Whatever I pray, nothing will happen. If there is no 2 millimeter buccal bone, I will have buccal resorption of bone. What should preserve? This technique, we call it bunch technique. Everybody know about it. We do it a lot before 20 years. For 10 years, we do more than 10 years. We do this. Because we don't know how much this is valuable. This gum, we don't know how much it is important for us. Cut it. Why? Because we call it that time, if anybody remember, implant without surgery. You remember this? This concept in Arabic, زراعة بلا جراحة. We keep putting it in our advertising. So people, they come like to put an implant, it's not surgery, something else. Yeah. And we used to cut the gum and throw it in the garbage. Now it's different. After IDC, we know how much it's very important to care about this gum. To deal with this gum, it's in very delicate way. To preserve it, to do all your best to keep it as it is. Now this implant, for Razan also, this implant, immediate implant, we extract, we put the implant, and we kept the healing cap. Now about the healing cap, we know about merge, submerge, and merge. You remember this concept? Submerge and merge. Here, when you can put the healing cap, when you cannot put the healing cap. Now we understand that it's depend to you, depend to your case. When you can put the healing cap, or you don't put it. It keep the implant cover. Now, if you need gum, if you see there is thickness in the gum, you have thick biotype, you can put the healing cap because you will preserve this gum. You will keep it there. So 2 millimeter of soft tissue, keratinized gingiva, all this concept, all this what you are seeing here, I know it here. Only in IDC, before IDC, I know nothing about this. I don't know why I have to put the healing cap. Even if I thought to put the healing cap after the implant directly just to save time for myself in the next surgery. That's why, nothing more yet. But now I know how it helps in some time. Now, this is also Razan. You see, we cut the gum, we open it, we take it from palatal, we take it to the labial, we put the healing cap here to wait for the healing. Now we ensure that we will have a very thick, nice gum. We will not lose the gum like we do usually by bunch technique or by laser. Also, we used to cut the gum. So now we understand. This is knowledge. To know why you are doing this, it is knowledge by itself. To know what you should do, this is also, you need knowledge to do it. Before IDC, we don't have the knowledge. After IDC, now we have the knowledge, and you have the knowledge, and you understand why we are doing this. Okay, it's boring? Okay, go ahead. Okay. Now we know how to deal with bone quality in the easiest and fastest way. The bone quality before, it was for us something like, I don't know why we read about D1, D2, D3, what exactly. In the end, we will make a hole. Then they told us, no, you have to make it, if it is hard to do like that. Okay, mainly if I'm in the maxilla, I have D4. What to do by D4? Put implant, not put implant, which implant, all this. Now we know how to deal with that. Which kind of implant, which design of implant, which kind of preparation you have to do. This is all knowledge. It's come together to give you ability to deal with this, any kind of bone you have. And we look to the bone in different way now. We are not carpenter, yes. We don't look to the bone like a wood. Now we look to the bone as a live tissue. How to deal with it. And especially about, as Dr. Razan, she was saying, about how to know about cells, and Dr. Mar'i also, he mentioned it. Cell-to-cell communication. Now we understand. Actually, we have, all of you, I think, you have this lecture where you was presenting one cell. Stem cell, macrophages, platelets. Now we understand all this movement what's happening in the body when we deal with implant or we put implant inside the bone. How do I deal with the quantity of bone in easiest and fastest way? How to make bone augmentation? How to put the membrane? What the best of bone augmentation? It depends to the case. About this knowledge, we'll talk about it, that there is a bone, it is the golden, we have to change this mind. Now here, because here we change our way of thinking, we change our mind, so not everything we heard before, or it was in literature before 20 years, it is like a holy thing coming from the sky. No, we can't think about it, right? So here we learn how to think. Okay. Why I need platform switching? This is my implant. Yes, this is my implant. You see, nothing as platform switching. Cement return. Actually, this case, 2 years I was having, in 2005, I was having a problem with this case exactly because he keep coming, because crowns keep coming out, because it's less than 4 millimeter. That time we don't know this concept of screw return. So my lab technician, he told me I will solve the problem, and he changed it to screw return. It was my first case for screw return, and by chance in 2005. Not because I know there is concept is to screw return. That time everything it was cement return. But you can see the bone resorption is very obvious, Yani. It's not okay. Now we understand why we need platform switching, not because only if we have a space or we doesn't have a space. In the exam you will find there is a question that's telling you if you doesn't have a space, If you have only 1 millimeter between the implant and the adjacent teeth, can you use platform switching? The answer, yes. Okay, this is what stuck to my mind, that I need platform switching only if I don't have a space. In real way, whatever space you have, you need the platform switching because of bacteria. Not because you want to transfer the bacteria from bone, crystal bone, to the implant half millimeter. And this exact information I learned here in IDSC. Before I don't know about that. Now, how do I plan? It's not where you found bone, you put your implant. No, you have to plan your implant, and it should be screw retain. Always screw retain. Cement retain is last choice. And for some very, very difficult or some places. Now this patient, immediate implant in the extraction, we put the healing cap. After we remove it, here 94 the ostial after 4 months. Here we don't use autogenic bone, 94. Can you imagine all this buccal side? We put it alloblast, which it is beta tricalcium sulfate. So as I mentioned before, the knowledge that autogenic bone is the golden, you have to think about it يعني شوي. Xenograft, you have to think شوي يعني little. Do it. شويتين. Do it. See, here it is alloblast. And after 4 months, this is what happened. We plan the implant right, we put it where we should, and here the result. This is the case. Okay. What really changed before 20 years and today, before 20 years, I never had a CBCT. I don't have CBCT. Now I hear from doctors they have CBCT that time. No? Me, I don't have. I used to do my implant without CBCT.
First iPad machine CBCT came out.
Really? In 2000, I don't have. Until 2010, I don't make one CBCT for any patient. We use only panoramic X-ray. And we used to have films, before digital panoramic X-ray, we used to have film like this. There is a sheet, it gives you the company of the implant, they give it to you. So you put your X-ray in that sheet and you choose the place of your implant. So only vertical. You can't think vertically, you cannot think horizontally, because nothing you can see horizontally. But after you open the flap, if you do it flap, surprise will come. Depend. يعني, it's like you remember when we was child, we used to buy something from shop. We call it in Arabic shahtak bakhtak. I don't know in your language. And you buy and you open. It's depend to your luck what you will get. And this is exactly implantology that time. In my time. I know I'm not saying everybody. So, but even so, yani, we did something, right? This implant I do in 2004 for a guy. He was my friend. That's why he keeps silent about that two implant. Even he doesn't know that. You see, this is flapless. That time it was always flapless. We do it flapless, as you see. I don't know why they are parallel and they're no. Maybe my hand become tired because I put 8 of them in one session. But good, right? Yani, these two implants for one lady in 2006 also. I bought for her this two implant. It was centrals, two centrals. The problem, after 1 year, she come with totally black. I don't have picture, but really she keep nagging because there was no buccal bone that time. That's why CBCT is something really nice, really good. It can show you before you do. That time we don't have, now we have. So it's something, wow. This really changed as equipment in our profession. Okay, one of the most important things that has changed after IDC. Who can guess? Nobody? يا أخي أي شيء, anything. Say anything. Okay, this movie. What? I don't hear you. Okay, what's the most important thing? That I can't think out of the box. I cannot be stuck to some information. I can make my own information. I can make my own articles. Can you imagine you can make articles? Any one of us can make articles, huh? Actually, now I know this with Dr. Suhail. Before I don't know. Any one of us can make some experiment, something. Not only follow what he have or what he read. Yeah. Okay. Now they teach us go for wider implant in immediate implant in posterior socket. So I say you don't need the wider implant. Just go little palatal or lingual. This patient, this implant sure, 6 implant, sure after IDSC, 78, he's diabetic patient, he's more than 8 actually. Okay, but now also we use for him the beta tricalcium sulfate as a bony graft, and this is the result after 4 months. So just go little, no need. Some company, I'm mad, some company, they will come to you, they will tell you, take our implant. Why? We have 0.6 implant, 6 millimeter implant, 6.5. Why you need that? Just tell me why. Why you need to put dead tissue in vital tissue, in live tissue? As much as live tissue you have, it's better. So put normal, 5, it's okay for posterior. Just put it little palatally or little lingually and keep your implant, and you will have very thick buccal wall and buccal soft tissue. Right? Now, this is the implant what I show you. I told you I will show you the full panoramic X-ray. You remember it? Coming. You don't need longer implant. Look how much long. We touched the nerve. The patient is still my patient till today, actually. But he feels. He's okay. He's alive. But this is, you see where it is? Why? Because that time they teach us, go longer as you can to have more bone, more stability. But even so, you remember that I show you the bone resorption. Now this implant, the patient, he keep having some buckets, some bleeding. He keep coming to me till today. I just make for him laser because he knows this is wrong and he doesn't want to do anything about the implant. Now, when you have a real long bone, just go deeper a little. Actually, this we learn here also. Go deeper. You see this implant? 3 millimeter deeper. It is dangerous to go deeper? It is bad to go deeper? Now, I know it is not. It is good. When you have an abutment like this, and try to make it thin as you can, platform switching, you can go deeper, right? And sure, you will not have more resorption here even after 30 years.
You can go deeper if the implant system provides you with long gingiva abutment. But the implant system does not have that. That's very dangerous too.
No, 5 millimeter is not this much deeper. Yeah? 5 to 6 millimeter. I think all companies, they have this much height. And even, it's a good point. You have to check that the system implant, they have high length of healing abutment. Yes, it is good point. Okay, this patient, we do him. This same patient, what you see, his implant is deep. Now we remove the healing abutment. You see how much deep it is. Actually, it's immediate implant. We extract. You know that. You know this cream, all of you. We extract. We put the implant, and directly after 4 months, we put the. You see the abutment, how long it is. I don't know, Dr. Suhail, what do you think about it? Good? Yeah, and we try to have thin abutment, and we put the crown. And they see, you see the gum side here? It is, the implant is palatal actually. We put bone, always we cover any gap we have. So it looks like this is what you can do here in IDSC. This is the information you can get. This is the knowledge you can get. This is the experience what you can get in IDSC. Thank you, IDSC, and thank you, Dr. Suhail. Thank you, everyone. I hope you like it. how it was short.